Good evening, everybody. Welcome to today's HOS meeting. So it's 7 o'clock and I'm going to start the meeting for the Health and Wellbeing and Scrutiny Committee. I would like to remind people that this is actually being recorded and so people can actually watch this meeting. So just be careful what you say, I guess. Okay. I've had apologies from Councillor Tandy and Councillor Piccolo. I don't think there's any other apologies, is there?
Kim. Oh.
Kim. Thank you. Sorry.
Yes, I'm Mark Tebbs. I'm the Chief Executive of CBS.
Thank you and welcome to today's meeting. Then I'll move on to minutes of the Health and Wellbeing Oversight Scrutiny Committee held on the 19th of July 2023. Do any members have any comments on the notes at all? Councillor Spate.
Sorry, thank you, Chair. It's not so much a comment on the minute itself, and I'm referring to item 8, the verbal update that we received, the CQC report on Basildon Hospital, and we had a number of senior members of the hospital management boards with us that evening, and it was, as we all witnessed, and indeed is recorded in the minutes, a fairly damning report. However, what concerns me greatly is, as a committee, we're here to hold people to account and to be made aware of the situations that are happening. Now, on the same day, I believe it was, as we had that meeting, an inquest took place. In fact, I think it may even have been the day before, where there was an absolutely damning report from the coroner on the level of care at Basildon Hospital, exactly the subject matter that we were here to discuss. It is inconceivable that the members of the team that were there that evening were not aware of that, and it's almost worse if they were unaware of it. And I'd just like to, if people are going to come to these meetings, we expect full openness, full honesty, full transparency, and we expect to hear the full story. And that report, for me to see that the following day from the coroner, it just shocked me to the core. And it was a horrific story of a man discharged to his death through the lack of care. The very subject matter we were discussing the evening before, and it just didn't come across, and they must have known. And if you remember, and I did apologise, I was rather caustic towards what should the directors of Basildon Hospital do, and I used the word they should resign, and afterwards I got the sense that it was probably an inappropriate thing for me to say, and because I made it personal. I almost now regret apologising, because if they're not going to tell the truth, then there's no point in coming to these sort of meetings. Thank you, Chair.
Okay, thank you, Councillor Spate. What I'd like to do is maybe deal with that subject on a slightly different agenda item as we go through the meeting, if I may. But other than that, are we agreed that these are a clear, accurate record of the meetings? Yes? So agreed, Councillor Spate? Chair. Agreed, Councillor Polly. Thank you. Right, now to item 3, urgent items of business. I've not received any urgent items of business. Does anyone wish to raise any points on any of the briefing notes?
Thank you.
Okay, then I'll move on to item 4. Does anyone have any declarations of interest to declare? No?
Yeah, I will just. Okay. Sorry, Chair, it's not a pecuniary interest, but as we know that I am employed by the NHS, and also I am appointed by this council as one of my outside bodies as on the Council of Governors for MSC. Thank you.
Thank you, Councillor Polly. Right, move on to agenda 5. We've agreed that Health Watch would have a 10-minute spot on this meeting, so can I hand over to you yourself?
Brilliant, thank you. Yes, I'll start with apologies from Kim. Kim James is not able to join us today, but she has asked me to provide an update to the committee in relation to cancer care. So Health Watch have received a number of concerns from Thurrock residents regarding long waits for cancer care. And we are, as our kind of role as Health Watch, kind of following that up in the normal way, supporting the residents to make complaints through the appropriate routes, and then if they're unsuccessful, then sort of taking up that kind of baton on their behalf, and then kind of escalating it through kind of the complaints management, through the alliance, and then to kind of senior managers. And I guess we kind of raise it with concern that those kind of normal escalation routes don't seem to be kind of manifesting in the responses that our residents need. So we are kind of following the processes that have historically worked and enabled us to kind of get answers and progress the complaints and concerns of the individual residents. And at the moment, it feels like we are just getting a lot of silence. And it's just concerning for us that those kind of systems and processes don't seem to be working in the way they were before. So we'll continue to do that. We'll continue to kind of raise the concerns and advocate for the individuals. We would just be very concerned if this situation continued and we weren't getting the responses that we think that our residents need.
Thank you for that. Have we got any specifics what you mean in terms of waiting long periods of time?
Yeah, so it's there's a kind of a number of themes. So one, the kind of waits from kind of initial GP referral to kind of initial contact, and then from that initial contact to kind of sort of decisions being made around kind of treatments. I think patients are feeling like they're just kind of being left, and there's this kind of vacuum in communication, and they're kind of frustrated that their attempts to kind of escalate concerns and complaints are just not being heard.
Councillor Polly?
Thank you, Chair. At the last meeting, this was brought up by Kim. It was mentioned, and I did say in my capacity as Governor that if she wanted to come to me, that I would then try to channel that in a different avenue, as she felt she hadn't. We had at that stage, as Governors, had a presentation on our updates, which I think the Health and Wellbeing Board had also had, predominantly from Mr Pike, regarding improvement, acknowledging that there was an issue with Southend and with the cancer care, and that advised us and gave us updates on significant improvements in certain areas, not underplaying the fact that there were still areas that needed to be improved. So are we focusing at Southend cancer treatment, and is it adult as opposed to children's cancer, or is it very generic? Thank you.
Yeah, I think it's generic. It's slightly unfortunate that Kim's not here, because she obviously kind of deals with the kind of individual complaints and probably has more details than I have to hand. So yeah, I guess probably we won't fully understand the themes, because we're kind of getting these kind of individual cases, and I guess our role is to be kind of trying to kind of advocate and kind of follow up on their behalf. But certainly we kind of feel like there's more than we were having before.
Councillor Polly.
Thank you, Chair. If I can come back then, I'd be quite happy to go back to Mr Pike and ask him for that presentation and arrange something where Health Watch and ourselves can actually go through the numbers, because obviously statistics are one thing, but Health Watch deals with real life patients, and this is what we mustn't do. We mustn't look at a spreadsheet and ignore the reality of the situation for that person, their care, and the effects that has on their family, their mental well-being as well as their physical well-being.
Councillor Spate.
Thank you, Chair. In the wake of Kim's figures that were delivered to the previous meeting, I think there was a sharp intake of breath among members. What we were told, that there was a sort of reticence on the other side of the table, and I'm almost harking back to the point I made when we were looking at the minutes. The matter was observed and taken up by the BBC Local Democracy Reporting Service, and in the wake of our meeting, they quizzed the hospitals about this situation, and were told in a formal comment, as I seem to recall, that the figures were wrong, and there wasn't the figures that Kim had quoted at the meeting were not correct and didn't represent the reality of the situation. That was the response that went out to the media. Has Health Watch had any direct responses in the light of, I mean, if they're going to say that to the media, then they should surely come back to Kim and say, actually, we've gone back and revisited the figures that you presented to the meeting, and we have actually analysed it, and actually they're not correct. Now, and that may well be perfectly valid, and it may well be that the trust is correct, but I just wonder whether you'd actually had that feedback as a body.
Not that I'm aware. I'm certainly not aware that we've had any kind of official response back from the hospital, although it's kind of part of the escalation of the kind of patient concerns that have been raised to us. We have escalated it to kind of director level within the trust. So, I'm not aware of any kind of official response we've had back. But I'd very much welcome your suggestion around having a meeting, so maybe we could combine some of the things we're hearing on the ground with some of the kind of trends and data that the hospital are seeing.
Councillor Polly.
Thank you, Chair. We can talk outside of this meeting. I'm very happy to work with you, and I'm sure that the Chair of the Governors as well would welcome that, because that's what we're there to do, is to be an overview on what's actually happening at the hospital. So I think that would be a good bit of collaborative working. Thank you.
Councillor Fish.
Thanks, Chair. Just wanted to try and make sure I understood the nature of the issue. I remember attending a health and wellbeing board a few years ago now. Mr. Pike was at the meeting. He was talking about cancer care, and he was saying that the aim was to achieve from visiting your GP to diagnosis within 4 weeks. So is it the case that patients are saying they're not treated within 4 weeks, or and that's their expectation at the start of it, or are they saying that they're just not hearing and the expectation for the 4 weeks is out the window?
So my understanding is the complaints are kind of delays at each kind of part of the pathway. So, from the point where the referral happens, there is kind of like extended delays in that kind of initial contact, and then after that initial contact, the decision to retreat is also taking some time, and that there's a kind of like a void in communication in the meantime. So.
Thank you. I myself have received some concerns from the press making inquiries about blood tests in cancer patients, and the period of time it's actually taken people to receive results from their tests around a possible diagnosis around cancer. So I wanted to just flag that up, because I know that the press are looking at this, and I'm going to try and get some more details, and I'll aim to come back to Alexander Mikan, is it? To get some details and investigation from this. This is an ongoing theme. I've only been chair of HOSC a few months, but I keep hearing this subject matter arising. So I would really value some feedback on this item in a meeting in the near future around, have we got any data relating to people from first being referred by the GP to actually starting treatment? Is that possible, or is that something I need to ask Alex about?
So I do have some of the latest figures, which I can share either now or in my update. But I think my reflection at this point is where we have individual patients in amongst the 6,000 per month that are referred into the hospital on the pathway that have a concern that we've got an escalation process that's not working. So I equally would like to input alongside yourselves to understand from the hospital end what we need to do to get those processes working. So I can cover that now or in my report in terms of where we are with the 28-day faster diagnosis standard for cancer.
Okay. If you'd cover it in your report, that'd be great. Is there anything else, Mark?
No, that's it. Thank you, Chair.
Thank you. Okay. Councillor Polly?
Sorry, Mark. Health Watch, you're Thurrock based, but obviously there'll be health watches throughout Essex and Southend that cover the MSE. Are you speaking with those health watches, those other health watches as well? Is it something that they're aware of?
Not that I'm aware of. I think we are, our remit is around the kind of Thurrock area. I'm not aware of any kind of wider collaborative working across the other health watches to see whether there's similar situations in their area.
Thank you. If I can please move on to item 8, then. Item 6 even. But before we move on, I think I want to keep an eye on this subject, actually. So I will keep bringing this up with you guys, and I'll be listening to what Health Watch have to say, and patients generally as they have contact with myself and other members. So I just want to let you know that. So I'd be grateful if we can keep an eye on that, please. Right. So update. Item 6 is update from Mid and South Essex Trust. This is something I've agreed to be regularly on the agenda. I think it'd be really, really helpful. And Fiona Ryan has kindly come along this evening to go to give us an update. So over to you, Fiona.
Thank you, Chair.
Fiona, do you know everybody?
I think I've met a lot of people in the room, but not everyone. So I'll introduce myself first. I'm Fiona Ryan. I'm Managing Director for Care Group 1, which essentially covers Basildon Hospital, Orsett, and a couple of our little smaller satellite sites. Thank you. So just to touch on the key issues, I'm aware that at the last meeting you had a briefing on the CQC report, which had recently been published at that time. I did hope that we would be in a position to give you an update on that particular acute issue where the rating for our medical services was deemed inadequate across all 3 of the hospital sites. I understand that there was some detail shared last time in terms of the nutrition, hydration concerns and the actions that have been taken associated with that. We did have a revisit from the CQC in early July. That was followed up with the usual submission of supporting evidence on the back of their data request. And we had expected to hear back around our warning notice in the following weeks, and we are still waiting that notification to come through from our CQC regulators. So we will, of course, update you through a press briefing and a stakeholder briefing as and when we are in receipt of that. The improvement work hasn't stopped. There's further work that we are doing across many elements of our care delivery, not least those elements that I will cover in relation to performance as we report it, but remembering that that reflects individual patients. So we have had three very high priority areas of focus in terms of recovering our hospitals, and particular Basildon Hospital, back to where it needs to be in terms of delivering for our population. A big focus around urgent and emergency care. You will know all too well of the poor performance that there was in relation to 4-hour waits for our patients that culminated in long delays with ambulance offload. I'm very pleased to report that MSC as a system is doing very well in supporting our ambulance partners with ambulance offload, and we're frequently the best area in the East of England ambulance service in supporting that. There's been a huge amount of effort, coordinated effort, I would say, across the 3 hospital sites, and we are now in a position to have systems and processes in place whereby we can flex our available capacity, as small as that is at any one moment, well across the system responsively, and we do have really good coordination with system partners on a daily basis, 7 days a week, as well, in supporting patients to be discharged safely. In relation to cancer, so there has been recent press, obviously, around the standards that we will be reporting against. The faster diagnostic standard, which is the 28-day standard that you referred to, Councillor. We are currently at 66.9% of our patients are receiving their diagnosis within 28 days. And we're working towards our target of 75% on that. That is a big improvement from where we've been, but obviously a way to go. But I reflect back to my earlier comment on the basis that in any one month we receive up to 6,000 referrals. That's still a lot of patients who aren't receiving that information and having that number of sleepless nights, etc. So that's why I think that work around the escalation process for patients who are sitting with that elevated level of concern is so important. The other standard that we are very focused upon is obviously our 62-day treatment standard. We currently have a reported backlog of 663 patients that are awaiting treatment or discharge over 62 days, so that's 2 months. It's quite a long time. That is a significant improvement from where we have been. We were looking at numbers in the thousands, and so it's an improvement, but obviously an improvement on a journey to a better place and not a completed piece of work. I think just to highlight a couple of things that are relevant for the local population in relation to the cancer services. So there's a couple of key bits in our pressured tumour sites that we're working on or in the midst of delivering that will support getting patients that diagnosis and therefore, if they do have cancer, that treatment more quickly. So our gynae pathway is an area of concern where we'd seen some quite long waits for patients to get into a test or an appointment. And so through July and August at Basildon Hospital, there's a suite of one-stop capacity coming online, so patients will be able to come along, see their clinician, have their test, and all in the one visit, which is a really good improvement. And I think the other thing to highlight is the teledermatology service that we are working with in the community. So they're patients that have got lesions, skin lesions that are of concern. It's a community-based streaming service. That's one of the services that sees the highest volumes of daily, weekly and monthly referrals coming through. So that is working in Mid-Essex and will be rolling out in the autumn across all 3 sites. So just to highlight where some of the transformation work is ongoing. I think to reflect back, I've used that number we do see referrals in the region of about 6,000 each month. That's an increase from, we talk a lot about our pre-pandemic baselines, of about 5,000. So quite a big increase each and every month. And it's really important that we operate our pathways differently in order to address that demand, because we don't have the physical clinic capacity, doctors, etc. We just need to be a bit smarter about how we get patients into tests and then in to see the doctor with those results, so that we're using our available capacity smartly. Now, I'm happy to pause as we go along, or do you want me to run through the priority list and then take questions, Councillor? Yep, okay. So I know that we've touched on blood tests, and I've been working with Michelle Stapleton to get some information through around what the plan is for Thurrock phlebotomy. Michelle's the managing director that looks after our clinical support services. I understand that it's a 4-week wait for phlebotomy appointments in Thurrock at the moment, and there is 2 pieces of work that they're doing. One is looking at the location of the capacity and how they can expand it, and the other is the DNA rate. So the DNA rate's quite high across the clinics. So they're looking at how they can both improve that and potentially just manage it through some overbooking. Always a little bit tricky to manage overbooking, but I'm just trying to see where we can make sure every available bit of our resource does get utilised for the benefit of patients. I've made a note around the blood tests for cancer patients, Councillor Hooper. I think that's something we'll need to come back to. I don't have any information. I haven't been cited to any concerns around that. In terms of, so those are obviously 2 of our immediate priorities, and the other is the size of our waiting list. So we have been working with the guidance of the national and regional teams to eliminate all of our 104-week waits. I mean, it's just mind-boggling. I grew up in an NHS where we talked about 18 weeks, so it's very difficult for teams sometimes to operate in the context, but the work is being done to support that. We are now working on a plan to address our 78-week waiters and then our 65-week waiters. So the waiting list is being managed down in that way. Obviously, where it's not a fixed number, because each day new patients are added to that waiting list. Obviously, on the 12th of July, there were 4,360 patients waiting for treatment on the Basildon waiting list. And that is down from a peak of last year of 4,808. But as you can see, because we are both adding as well as removing, that is a challenge. We have seen some challenges around some of our really long waiters and the impacts of the consultant strikes, but we manage that. We micromanage that on a patient level basis, and report that up to our regional colleagues. I think just to add, we've obviously got work ongoing around the CDC, so improving access to diagnostics for our population, with the Grays Centre due to open in 24, and then PIDC following on from that, and then we'll be working on CDCs in both Southend and Braintree. And I think then just lastly, winter planning. So we are at that point of the year that, even though it hasn't felt like summer, it's felt a lot like winter at times, and we don't seem to have a summer in the NHS in the way that we would have done in years gone by. We are working with our ICS partners around our winter plan. We are looking very, very specifically for really robust plans that allow us to manage the increase in demand that we know that will come with patients in community locations. And there's some very, very clear reasons for that. We saw the impact of a very difficult winter on the acute hospital sites, where capacity was extended with escalation beds and workforce overstretched as a result, and the resulting impacts on the quality of what was going on in the hospital. So as a system, we're working together to make sure that we can utilise every community bed, every virtual ward bed, all of those innovative schemes so that we can support patients. And in support of that, we've got a system winter plan coming together. That's also looking at some of the community bed provision. We've got some issues across Essex in relation to St Peter's provision, and we're looking to see how we can use the Brentwood Community Hospital site optimally. I don't believe there's any proposed changes to intermediate care capacity in the Thurrock area that I'm aware of or that I need to alert you of at this point. Okay.
Thank you very much. Are there any questions?
Several.
Councillor Fish.
Got a couple of questions about the CQC report inspection that you mentioned, and you haven't had the results of it yet. Was that an announced inspection or unannounced? And was it part of the process of the original inspection that you had?
So ordinarily, when you are in receipt of a warning notice on the back of a CQC inspection, it is expected that they will return within 3 months to reevaluate the situation. And that's so it was expected but unannounced at the time that it happens.
Okay. And another question about the haematology service. I've been referred to the haematology service, but it's actually taken so long to get the appointment that I've actually healed up now, so I don't need the service anymore. What is the average waiting time now for the haematology service?
I'm sorry, I don't have the service-specific waiting time for that, but I can come back to you on that.
Would you say, is your general impression that it's improving?
I wouldn't want to comment on any service-specific capacity that I don't have direct line of sight of, but I'm more than happy to bring that back to you. I think we've got an overall improving trend that we are working very hard to keep pace with, but I can't rule out any service-specific issues, and haematology is not an area that I directly manage.
Okay, I'd be interested in, I think hopefully the rest of the committee would be interested to see figures on that, and just like a comparison so we can see which direction it's moving in. Thank you.
Thank you, Councillor Fish. Councillor Spate.
Yeah, when you were reporting back on the figures for the diagnosis, you mentioned that you got 66% that were on 28 days, and then you made reference to the target is to get 75%. I find that a very low expectation level. I mean, I appreciate the reality and a vision of perfection are far removed in this day and age. But to set a target of achievement of 75% seems to me incredibly low. And it seems to be an administrative way of saying, oh, we can get to that and it looks like we're done. So if we're doing a RAG report, we can say we've got some greens because we've set the targets very low. And, 75% still means 1 in 4 as being let down. It's great to say 3 out of 4 are getting a service within 28 days. Who and why are these targets set so low? Because 75% to me just seems extraordinarily low. Smacks of a lack of ambition.
So I'll attempt to answer that to the best of my ability. I think the rationale for moving from what was the 2-week wait standard, whereby it was required that you had your first contact, be that an outpatient appointment or a test, within 2 weeks on the cancer pathway, has been replaced by that 4-week standard because it's focused on actually getting a diagnosis, or be that benign or otherwise, to a patient in a 4-week time frame. I think the reality is that one test often doesn't give a confirmed diagnosis for a patient, so they may require 2, 3 or 4 diagnostic tests, and I think the standard reflects that in some tumour sites and for some patients it may require a number of tests to happen sequentially in order to reach that confirmed position.
Yeah, I don't think maybe the answer is not disingenuous deliberately, but do you not get the point that I'm trying to make? I get what you're saying about waiting times and whatever, but I go back to the point that I was trying to make, and probably I didn't make it very well, which I apologise. But I just think what you're saying is, our expectation is to have a target of 75% of target. I just don't think that it is reasonable for the general public of our borough or Basildon or wherever to have a health service that says, yeah, we're only, our target is 75% success. I just find that astonishing. It just smacks of apathy and a level of bureaucracy that says, well, if we do that, as I say, we'll have I hate ratings because people set targets so they produce a piece of paper that's full of green dots, and it actually could be really bad news, but it's got green dots on it. So I would take it. I go back to the issue that I raised earlier on, in this coroner's report about your trust's administration, who described it as, a chronic lack of professionalism. It remains a grave concern. So these are comments being made by far more educated people than me, far more expert people than me, and saying that the administration within the hospital trust, it's directly avoided the trust, it's just low. It's just too low to me. But I may be in a minority, but I find it shocking that targets are set at 75%.
I think from my perspective, it'd be good to review how you're progressing from 66 or 67% to 75 and what the ambition is after that. Because I have some sympathy with that view. You're talking about like 6,000 referrals a month, and you're talking about over 1,000 people a month not getting it within the time frame. So I think it's something to come back and revisit if we can just keep an eye on that. Yeah.
Yeah, more than happy to.
And I'd be really, really interested to know also, as we're talking, I'm always interested to know how Thurrock can help support what you're doing. Okay? I don't want to feel like we're bashing you over the head, because it does feel like a bit like that sometimes. Okay. Councillor Polly.
Thank you, Chair. I've also got a couple of questions. The CQC visit in early July, was that based on their new criteria? Because they have different criteria for what they're assessing. I think their current one is patient-centred care. Is that correct?
So the visit in July was targeted specifically at the issues that were identified with the medical services and the warning notice associated with it. The inspectors were obviously clearly free to address anything else that they chose to, but their attendance at that time was very specifically focused on reviewing those concerns.
Thank you. And you made reference to the do not attend the DNAs as regards to blood tests, as you quite rightly described. It is approximately a 4-week wait if you use the SwiftQ system. One of the things that I'm having residents come to me about, and I have raised it, and there is an audit trail on some of the questions that I've raised, was the phlebotomy walk-in service at Allset has been removed. That's gone to appointment only. I've got residents that, in line with the concerns with Health Watch, that without being too specific, are under treatment with Southend Hospital. Southend Hospital phones them up on a Thursday or Friday. He says, we've got capacity or space for you on Monday. Can you go and get your bloods done? They've popped along to Allsett Hospital or Allsett phlebotomy services in the past on Saturday morning, got the bloods done so that they're there for Monday morning, so that everybody, it's all in alignment. By withdrawing that service, that patient now can't do that, and there was no notification for the withdrawal service. The service users, the groups such as Health Watch or Council weren't informed that this was just going to be removed. So this patient went along on Saturday, there was no service there, was unable to have their treatment on the Monday because the bloods weren't done, which then stopped the course of treatment they were already under. So there is, they are two things that are quite heavily combined, I think, within Thurrock, is the lack of blood testing and the not just the CO results, but patients in that scenario where they're not in a position to go get their blood test form from a doctor and then wait 2 weeks or that they haven't got that. There's very few walk-in appointments. I think Thurrock Hospital is possibly the only place now where you can walk in. You've got to be able to get there for a start. But even that, they've got limited appointments, and it's only a Monday to Friday service as well. So I would welcome a more detailed investigation into the phlebotomy services in Thurrock.
Are you happy, Chair, if I take that and do some work with our phlebotomy team? I think those patient-identified impacts are really important. I don't directly manage phlebotomy, but I did in a past life or in a past role, and certainly at that time we had direct access in for these patients. We had like a red dot system so they could go in, so I can't respond to, unfortunately, the detail around what happened, but we can certainly do the work together to address it and bring it back. I think that I have asked the phlebotomy team in preparation for today that they prepare, in effect, a future capacity plan for Thurrock to address those long waits, because regardless of already having that cancer diagnosis, 4 weeks is too long to wait for a blood test.
Mark.
Yeah, I'd just like to follow up about the winter planning item. I think the voluntary sector can play a really important role in kind of supporting the kind of winter planning. We run a service by your side that kind of supports kind of discharging. So it was just a question whether the voluntary sector is being considered as part of that winter planning, and a plea really that if they are, that we kind of have enough time and notice to be able to kind of mobilise services. Some of our experience has been that when we are considered, the notification comes really late, and then it's almost kind of we're over winter before we're able to kind of mobilise those services. So, yeah, a plea to be considered, and two, that we kind of have some really early dialogue to kind of see what's possible, and we can get the support in place as early as possible.
Yes, certainly on the list. Sam Goldberg is coordinating on behalf of the ICB, and so if you haven't had her reach out as yet, we'll make sure that happens.
Okay, thank you, Fiona. I feel the need to move on because of time. I do have a number of questions which I may come back to at another time, but we will record in this meeting. Okay, but in terms of the CQC inspection, I want a bit more of an update in terms of where we are in terms of staffing and the training of those staff, patient feedback on their experience, and obviously if you hear from the Care Quality Commission about any inspections, some feedback on the report would be really, really valuable. Okay. I do briefly want to raise the point that Councillor Spate has raised around concerns about a gentleman that came out of the hospital, but my understanding and sadly passed away due to poor care. Not due to poor care in terms of, it's more about the state I think he left the hospital in, if I remember the case correctly. This is being looked at in terms of a complaint or concern or a safeguarding.
I don't have the specific details of that, but I will confirm back to the committee.
Can I ask Jim if you've got any knowledge of this? Okay, so we'd like to get a report on that at some point in terms of, I think there are 3 cases of concern from Basildon Hospital. Thank you very much. Thank you. Right. If people are happy, could I move on to the next agenda, which is item 7, the annual complaints report. And I think Lee Henley is going to do a presentation. So over to you, Lee.
Thank you, Chair. I'll provide a high-level overview of the report and happy to take any questions. So this is our annual adult social care complaints report. Overall complaints have reduced, and we go out of our way to capture complaints with a range of awareness campaigns. There's been a slight improvement in performance compared to last year, with 85% of those complaints responded to within time frame. Our compliments have increased compared to the previous year. Pages 19 to 26 of the report captures learning from complaints based on those upheld complaints. The key themes that came across this year were standard of care and communication. And to ensure we learn from those complaints, our contracts and commissioning team carry out compliance visits to care homes we run and those by external providers. And during those visits, they take a sample of those upheld complaints and make sure that learning has been embedded. We've got some good examples of learning for compliments, and they're actually reported on pages 34 and 35. Happy to take any questions.
Well, thank you for the report. Very grateful. One of the things I notice is, in my experience, the number of complaints are quite low. That may be a good thing or a bad thing. Do you feel we're doing sufficient enough? Do services do enough to actually promote the opportunity to make a complaint and a compliment?
My team write to providers quarterly to capture complaints information. We've produced posters that have gone up in care homes to raise the awareness amongst service users with regards to how they can make a complaint. We think we've done as much as we can. I agree the complaint numbers do seem low, but we are going out of our way to try and capture those.
Okay. So I don't see complaints as necessarily a bad thing.
It can be. It's a good thing to learn from that. Learn, yeah.
And I'm really pleased to see that compliments have increased. So that's really, really good to see. So well done to the organisations, all the staff all the services you work with. Do you have any questions? Councillor Fish.
Yeah, I was going to ask whether you think it's a good or a bad thing that the complaints have reduced, but Chair's already asked that one. But my other one is about the learning. I'm always interested in the learning from the complaints. And I noticed that in the tables here, you've given details of different complaints, and you've given details of the outcome, you might say. And you said that the compliance team then take a sample. In each of these complaints, I would have thought it would be possible to follow up whether that learning has been embedded. So, I mean, it's not something you can do to make sure that each of the complaints we get the outcome here.
Yeah, just to reassure you, so I think we've got a really strong compliance and brokerage team that has very good relationships with all of our commission providers. In every case, this learning will be followed up by that team. Furthermore, if there's a theme that's emerging, they undertake they undertake a visit, a rolling programme, what's called PAMS. I forget what PAMS stands for now, PAMS, but it's the equivalent of a dummy CQC inspection. So we inspect our team, all of our commission providers, on a regular basis, far more regular than CQC. If there are themes coming through in terms of a pattern of complaints in a particular provider, then we would step up those inspections as frequently as quarterly. But each one where the complaint's upheld, then the team goes in to check that the learning is embedded and follows that up.
Thanks very much. That's really good to hear. When I was portfolio holder, I did actually go out to the compliance team on some visits, and I was very impressed how thorough it was in those days. So it's good to hear it's still the same. Thank you.
On a broader point, the quality on the PAMS visits, our providers in general is really strong. So, for example, 100% of those residential or learning disability placement are cared for by a provider that is either good or outstanding on a CQC or PAMS rating. It's about 91%, I think, for older people. So it's something we take really, really seriously.
Councillor Spade?
Yeah, I was actually going to make the point that you made about the compliments. That was really good to see. I come here quite a lot with brickbats, so bouquets should be handed out as and when, and it does make really good reading. And the only thing that's just, and for example, you see the one where I won't name it, but was presumably closed down on the back of. Sorry, that was on the investigation side. I'm mixing myself up. The question I was going to ask is, in terms of the number of complaints we're getting, are you happy that we are making enough avenues for people to complain? Because we have a digital first world in Thurrock, and a staggering number of people who probably use these services are not in that digital first world. And it's a question that I've asked on a number of services, including housing, where I'd say, are you happy that you have the resource available to you to go out and also do the physical checking that you may need to do, where those people who might complain are not able to because they can't get to us? So, we as a committee, if you identify to us that we could actually do some more support or have a better way of researching this, we would be duty bound, and quite rightly so, to sort of help you. But I think it's a very positive report, and as I say, rather than just dish out nasty things, it is nice to see something that's really positive, and let's have more of it.
Just on your resources question, I think this is, unlike many areas of adult social care and resources, I think this is one where I am confident in terms of the resources we've got. That, as I say, that team's a really high-performing team. On your digital challenge question, which is a very, very good one, again, I'm confident people can complain through a variety of different channels, including picking up the phone or writing. We actively survey our recipients of care as well, and encourage proactive feedback. So it's not just a reactive service, it's certainly not digital. I think it's always really hard to interpret this data. So on one level, I think we have over 10,000 individual packages of care provided per annum, hundreds of thousands of hours. And on one level, you could say this is a really, really good news story. On another, and I say this every year when this comes to committee, it concerns me. It's a little bit like the safeguarding data that we're about to see a bit later. It concerns me. Is there a cohort of people that are reluctant to complain? I worry that because quite a lot of the recipients of care are quite vulnerable, there's a reticence, a misplaced reticence, but a reticence nonetheless that they shouldn't make a fuss in case it might affect further care going forward. But as Lee has articulated, I think we do everything we possibly can, both proactively and reactively, to make it easy to complain.
Thank you. Lee, thank you very much for the report. Again, it makes good reading, but part of me does feel like I want to see a few more complaints. Councillor Polly, do you want to raise something?
Please, if I could, Chair. Going through the complaints, predominantly these are organised, structured, either care homes or hospital, or the service users that receive care in their home directly. So I would suggest that your strategy is working. And obviously there are some care homes that are reappearing in the report. So I think that shows that they're embracing the system and are doing the duty of candour quite well and inviting those comments to be investigated, which is what we'd like to see on a wider spectrum. But when we're delivering services to homes to individuals that possibly are more vulnerable, whether they be a dementia patient, whether they be somebody with special educational learning needs or of that, where's their advocate? Who goes and visits them and checks that they are receiving the service? I'm sure it's already in the ether there, Ian, but I just, as this report is, I can't see, other than the person stepping off at the minibus, I can't see a report from an individual, and I might be wrong on that, sorry.
I think you are wrong, actually. I think complaint 3 was home care, if you have a look at it. But the point you make is an entirely reasonable one, and the level of complaints from home care recipients is exceptionally low. There was a few in terms of Thurrock care at home, again, is home care. To reassure you, the service that I describe in terms of compliance and brokerage covers home care as well as residential care. So again, we would continue to do inspections, both planned and unplanned. If there were themes, we would go out and investigate. We proactively survey recipients of home care. So, and we do that rolling programme, and if necessary, a stepped-up programme of compliance visits that dummy the CQC inspection in between the formal inspections through the PAM system.
Okay, thank you.
Okay, Councillor Spade.
Sorry, I was interested in the compliance visits. I've had personal experience of a care home in the borough where I visited and I was very disappointed. And it was like just me turning up randomly on the day and whatever. And it actually was. It ended up being very positive because I went to see the manager and I said, "Let's deal with it." So you're quite strong on compliance visits, unannounced, as it were.
Absolutely, yeah. We will turn up unannounced with a team of people and say, "Let us in," and they do.
Okay, so if there's no more questions, I think that the Health, Wellbeing and Overview Scrutiny Committee have considered and noted your report.
Agreed.
Agreed? Thank you. You can go, Lee, if you want to go, or are you happy to stay? Okay, if I move on to item 8, which is Thurrock Safeguarding Adult Board Strategic Plan. I welcome the Independent Chair of Safeguarding and Adults, Jim Nicholson.
Thank you, Chair. This item is supported by 3 papers in your bundle, the covering report, the strategic plan itself, and a PowerPoint presentation. With your permission, Chair, I think if I just make some brief remarks to the PowerPoint presentation, it will pick up all the points I was hoping to make. There's actually a 4th document which only arrived this morning, which is an easy-read version of the strategy. It's excellent, and it's for people who would obviously find it rather daunting ploughing through a formal strategy. That's been sent to Democratic Services this morning with a request that goes out to members with the minutes. So looking at the PowerPoint itself, I wasn't going to say too much about the aim or the vision. The role of the board, it identifies 3 core duties. These are legal responsibilities as set out by the Care Act of 2014. And as you can see, the first is to publish a strategic plan, which is what I will be talking about now. Secondly, to publish an annual report, and I'm coming back to HOSC on 2nd of November to present that report. And thirdly, to carry out safeguarding adult reviews. These are reviews when people in care or who are in need of care either die or become seriously ill and circumstances require further examination. And we undertake these, and I'll be making further reference to that shortly. The next page just goes into a bit more detail about these sorts of things. We conduct regularly audits to make sure we're actually achieving all these, and I'm happy to report that that is the case. I hope I'm not going too fast, Chair, but I think it's just pretty clear. The next page explains who our partners are, then the board structure, and what adult safeguarding actually comprises, which I think is well understood by colleagues. Then we come on to some selections of the data that we use, and I think it's fair to say that it's not the most sophisticated data, and I'm grateful to Ian Wake for his great help in this. We are in the process of updating that, upgrading that substantially. The data we have here essentially is of adult social care. What we don't have is data that reflects the engagement of police and of health in any adequate way. That is changing now, and I look forward to reporting in the future on updates on this plan that will demonstrate that. One of the problems with safeguarding generally is it can run very close to the agendas of other boards, typically the Community Safety Partnership. And if you look at the strategy, it's a 27-page document. 21 pages are references to other people's strategies and things, which explains where we've come from and the processes we've gone through and the consultation we've gone through. But it does mean that we need either to be, my job very much is to make sure that we don't duplicate or have mission creep and take on the work of other boards. And with that in mind, what we've done here is we've gone to the 6 elements, if you like, of what safeguarding is all about. And so these have been the framework on which we hung the actual strategy. The first one, empowerment. All I was going to say, reflecting what previous conversations, is that we're working closely with Health Watch to commission some work where they can independently review the outcome of treatment and see how care service users feel about what they've received. And that feedback loop will inform how we progress in the future. The other point I need to make is that these priorities are supported by a highly detailed delivery plan, which isn't before you tonight, which sets out exactly how we're going to do this, when it's going to be done, and that will be reported back to board. Each priority has got its own dedicated work group and an identified lead who will be responsible for the reporting progress. On priority 2, prevention, the bullet points, I'd just like to make a comment about the first 2. I think it's fair to say that we've all very much focused our communication with an increasingly sophisticated IT, websites and such. But of course, for many people, they don't access websites. They don't have smartphones. My wife doesn't, for example. That's something else. And yet these are the very people we're trying to get to. So I just wanted to say that we've recognised that, and we've taken some time. We bought some time from a community engagement officer to actually make sure that through the community hubs and through other means, people are getting access to the information we're trying to put out, as well as the websites, etc. I'm going on now to proportionality, and this again is about minimum intrusion by staff on people's lives, but also about having multi-agency safeguarding data, which I've mentioned, and also to audit activities. So when things don't work or aren't working as well as we want, we actually have an audit group in place which will scrutinise that and find out what isn't working as well as it should, and put in the necessary countermeasures. Protection. Here we focused greatly on transitional safeguarding. It was one of the 4 priorities we had in our last strategic plan, and we've gone from not very good. This is shared with children. You know, we've made a lot of progress here, but there's a lot more yet to be done. We're talking usually about very small numbers of people, but this is fundamental stuff for people at the early stage in their lives, and so therefore that's something which we think merits a lot of our attention for the future. Partnership. This touches on my earlier point about working alongside but not duplicating the work of others. And again, there's a reference here to the Community Safety Partnership. We've collaborated with them on a number of events. We ran a modern slavery conference that I'll be reporting back on in November. And I'll be chairing a conference of theirs again in November. So we work very closely together, but acutely aware of the differences and the margins between our areas of work. And the last one that we'll be looking at is about accountability, and it's about holding partners to account. And this chimes very directly with what's been said earlier in the meeting about Basildon Hospital. We became aware, as others did, about concerns, and I commissioned a thematic safeguarding adult review into a number of features of their performance. That has produced a set of robust recommendations, and the representative on the board is shortly to leave, and it's a priority of mine to have a very early conversation with the replacement to make sure they fully understand the depth of concern that has been expressed this evening, for example, as well as working together to make the progress that we want to have. And the SAR has a very detailed implementation plan to address these points. And again, that's something that I know members of the Safeguarding Adult Board will be very anxious to have detailed updates as soon as possible. This is followed by progress on how we did over the last 3 years. I wasn't going to say anything to this because this forms the basis of the report I'll be bringing back in November, and it's pretty self-explanatory, really. So I was, with that comment, I was going to pause there and see if there's anything I can help members with.
Any questions? Councillor Fish.
I'm a bit puzzled, really, by the themes that are in here, because it strikes me that if this is your sort of strategy going forward, why wasn't the strategy go, in the past? It's the themes here seem to be perfectly reasonable things to do, but the sort of things I would have expected to have been done in the past.
Well, I would say that this isn't new work in many areas. This is stuff that we have been doing. It's just that we parcelled it up in this framework so that we are focusing very much on the safeguarding perspective rather than a rather more loosely drawn one, which might be true of what we've done in the past. So it's about focusing more of our efforts explicitly on the safeguarding element of them. But I take your point. I mean, if I was to go through the feedback on the previous 3-year strategy, you'll recognise that a lot of the things we're talking about that we'll be carrying on with have already been addressed in this.
Yeah, okay. The other thing is, I thought, if you're going to consult on this strategy, there's quite a bit of jargon in there. There's reference to other reports, and if you're going to do a proper job of as somebody who's being consulted, then you'd have to wade through all these other reports to be able to say whether you think it's reasonable.
It's a very fair point, but I would say in response to that if you have a moment to read the strategy itself, it goes into great detail about what the constitutive process was. It was extremely detailed, extremely effective, and of course we recognise that this is not especially palatable for many people. That's why the easy read version that I mentioned does put that in a way that perhaps is more readily understood.
Okay, I've got one final point. I saw a table. It's not actually in the presentation you just done, but it was like a pie chart, and it said something like 70% of people that were consulted said that they felt that they could recognise when abuse is taking place. I'm not sure whether that's a good thing, because they were confident they could recognise it. Because I've, as a school governor, I've done courses on abuse, recognising abuse, and some of it really isn't that obvious. It's not always going to be somebody who's, obviously struggling. So, I mean, would you agree that 70% is not necessarily a good thing?
Well, I think that has to be taken in the context. It's one thing to recognise that there is a problem. Secondly, something we're very committed to is then making sure that people understand what options are open to them to take further action in terms of reporting lines and things like that, and bringing to notice to the agencies. It's undoubtedly true that some abuse, if you look at the wider definitions of domestic abuse, some of that is very, very difficult to observe unless the victim, the survivor, brings it to notice themselves. But it's about giving people confidence that if they did do that, they would get a professional response to their problems. I understand your point precisely, and I'm not disagreeing with you, but I would say that there's a momentum that's coming now through all the work that we've been doing, which is, I think, going to deliver well above that 70% figure. But I take the point about that's what we've said, so that's what I have to respond to. But I think we could look to increasing that in the future.
Yeah, just to come back on that, I'd say 70% with a caveat that they know, as you say, how to report it and how to take that further if they have concerns.
Yeah, sorry, I'm not quite sure I understood the point.
Well, I started off by saying that I thought 70% of people saying they were confident they know what abuse is. I'm not sure whether that's a good thing, because they may not, they might miss some. But on the other hand, if they're reporting everything that they see, at least it will be investigated, and that's a good
I'm
thing.
sorry. Yes, absolutely. And one of the features I haven't mentioned so far that underpins all of this is the whole concept of making safeguarding personal. So it's about identifying what service users want, and then checking whether what they wanted to have happen did actually happen. And again, in the strategy itself, you will see the figures that show we are achieving over 90% in that regard. And in fact, on those that we're not, that's when we called in the audit group to say, well, why not? What's that about? And so we've had satisfactory explanations about why that wasn't 100%. Thank you.
Thank you. Thank you for this presentation. It was a joy to read something that was simple to read, that told a story. It had a good narrative, and if there are areas like Councillor Fish just picked out, you're able to spot them. So thank you. It was really, really nice to see. I sat through at the Housing Committee meeting, I think it was a meeting or a working day a while ago, when we looked at the data source that you've got, the dashboard and whatever. And my one fear there, again, was that we were over-engineering something, because we'd got, and I'm going to be really awful and use that word, nerds, which is not meant to be derogatory in any way, but I couldn't think, we got some guys who we said, go and build a system, and they were, wow, this is great, and they built and they're building a system, and from what I understand, a very good system, and I assume it's the same basic system that you're using here, the power
Power BI.
Power BI, yeah. So that was good. And I was going to, having read that, one of the things that I was going to ask, you've actually answered, but I just thought I would flag it up again. And it's the old thing about communicating in other ways. And I was really impressed with what you said about sort of going out and not just doing it as digital and addressing it. And what I would suggest is, because sometimes it's nice for us to throw ideas, and I spend an awful lot of time in what I do professionally, dealing with a lot of the older people's groups, and there's a great strength of character among that age group where they will, they'll soldier on regardless, and they don't want to complain because it's not the done thing, and yet they may have valid causes for complaint, or not necessarily complaint, but of concern, and then we can make a service better. So I really do welcome that, and I would say, if we, and I know you spoke about engaging with a huge number of groups, but there are people out there that bring people together. But organisations like, and I'll just pick one off the shelf, Re-Engage, where every week in Thurrock they're bringing together lonely and vulnerable people and having a jolly nice time in a tea party. But I suspect there's also information you could glean from approaching organisations like that, and the people that run Re-Engage are really good, and I'm sure they would welcome, engagement with yourselves. So
I will check that. I think that is done, but if it's not, I'll make sure it is.
May well be, but there are out there, and I remember standing on stage and talking to toffs and people like that, and that human contact is invaluable. So great, we've got our fantastic team building a brilliant dashboard. Really welcome the fact that you're saying, but we've also got the human element in there. So thank you.
I wonder if I could just respond to that to say that I went through perhaps too hastily. The purpose of that work is not to produce the definitive dashboard. The purpose of that is to direct scarce resources into the right areas of action. And in regard to engagement with the community, the other two members of the Safeguarding Adult Board team will be at the Orchard Show on Saturday, doing precisely what you just said, Councillor. Thank you.
Thank you, Councillor. Councillor Polly.
Thank you, Chair. The priority forward to strengthen transitional safeguarding arrangements. We mentioned in there that we've got improved information sharing between children and adult services for young people at risk of exploitation. We can celebrate a very strong, diverse culture and community here in Thurrock. Are we engaging with non-traditional groups? Are we using languages that are not for people whose first language isn't necessarily English? Invariably, isn't it? It's those very remote, harder to reach groups that are most vulnerable to various forms of exploitation.
I mean, this priority is one from the last strategy, so again I'll be talking about this next time, but what I will say is one of the areas of work that we've got is engagement with the faith groups, because we see a very obvious and successful route is through the churches. Some are more easy to access than others, I need to say, but nevertheless that's something that we are working on, and with some success, and it's about, we have to explore every possible opportunity, some of which work better than others, but unless we try them all, we don't know. I mean, we've got to keep trying it. It's not the case that we identify a slick brochure and think, well, that's that fixed. It's clearly not. So we're always looking for ideas, and might I ask if councillors do become aware of groups that we could engage with, we'd be delighted to know about them.
Just to follow up on that, because it's a really good point, I think we try our best, but we can always do more. I think elected members do have a role to play as the community leaders and representatives of your community as well. So would be, as Jim says, really, really pleased to work with you. We are, again, as Jim has alluded to, commissioning Health Watch as well, in terms of that proactive user engagement, and I know there's some scoping meetings on that coming up, and as part of that process we need to ensure, and actually Health Watch have a really strong track record, I think, in terms of being incredibly blessed and fortunate in terms of the breadth and depth of community reach that you have, and the quality of the research that you've done in the past. So I think we can pick up that really valid concern as part of that process as well.
I wonder if I might add to that. Mark and I have had a brief conversation about not doing this as a one-off, but about exploring other ways to make use of Health Watch's expertise.
By all means, I mean, we have in the room the portfolio holder for communities as well, so I'm glad he's hearing this message. We have other multi-faith organisations as well, and I think we have committees where that information is shared. Used to be called Sacred, but I'm not sure what it's called now. But we can certainly look at that, and I definitely would very much welcome engagement with organisations that you're probably already involved with, such as Thurrock and that, because I think they have a long-standing presence in Thurrock and the work that they've done, especially around sex exploitation. I think we've got a lot to learn from them. They're an amazing organisation.
We work very closely with Thurrock, and that sexual exploitation study was a brilliant example of working together. But again, there are so many organisations and groups in Thurrock that we don't think we can't claim we know them all. So if anybody has anybody that might benefit from some engagement from us, we'd welcome that contact.
Thank
you.
Thank you, Jim. I think it's a really good report. I thank you for your work and what Thurrock Safeguarding Adult Board do. I'm particularly pleased to see that there's a large amount of work looking at learning and partnership working, which I think is vital in this work. Just a question, my naivety, my apologies. I'm really keen on looking at some of the outcomes of the strategy. So in terms of reporting back, what's the plan over the life of the 3-year life of this strategy?
Well, it's just started, so we're going to work out a timetable in the delivery plan that I keep alluding to, but haven't been able to show you tonight. It does have timescales on that, so I think at those key points, that might be an opportune moment for me to come back to this committee and say, this is how we're going so far. It's either delivering famously or it's not. That plate isn't spinning. So we need to work harder on that. But I think it's something that I hope members will feel very eager to be aware of, because this sort of work runs across so much else that we're doing, and it's right members are fully briefed on where we're going and how it's going.
That'd be great. I think we'll look at maybe sorting out some dates to come to future meetings with an update. And if there's anything we can do to help, please do let us know.
That's most kind of you, thank you. And obviously I'm back at the November meeting with the annual report, so I can maybe have something to tell you then.
Okay, thank you. So if it's okay, do members agree with the following recommendation? The Health, Wellbeing, Overview Scrutiny Committee members note the strategy plan. Noted. Thank you very, very much. Thank you, Jim. Right, if I can kindly move on to the next item, which is the tobacco control strategy. So that's Jo, isn't it? Yes?
Yes, thank you, Chair. So you have the full whole system tobacco control strategy in your papers. You've also got a shortened PowerPoint presentation in hard copy. Like Jim, I won't go through this word for word, but I would like to pull out just a few key points for the committee, if that's all right. So the public health team have led the work on this strategy on behalf of the Thurrock Integrated Care Alliance, and the partners of the Alliance who've contributed to this are on our first slide there. In terms of context, though, I think it's important to just stress
why we need this strategy and why this is still an important issue for Thurrock. We know that smoking rates have fallen substantially in recent years, which is really, really good news. However, smoking remains one of the key avoidable drivers of premature mortality that we have. It's a key driver of respiratory disease, cardiovascular disease and cancer. It's also one of the key drivers of inequalities, because we see inequalities in rates of smoking and therefore inequalities in consequent ill health that plays through into premature mortality and the differences we see in life expectancy across Thurrock. So, although our smoking rates have fallen, around 12%, just over 12% of our adult population still smoke and are therefore at a risk of avoidable ill health. So we've developed this strategy to try and reduce that further. Thurrock is not an outlier compared to national rates. We're very similar to national smoking rates. And our strategy has essentially two aims. Firstly, to reduce by 2030 the smoking rate in Thurrock to 5%, which is the national target. Now, that's going to be incredibly challenging from where we are and given what we know about smoking in different groups currently, but that is our ambition. And then the second element is to reduce that inequality burden that is as a result of smoking. So in terms of those inequalities, and I'm looking at slides 3 and 4 now, we know that there are certain groups in the community that have higher smoking rates. So although it's 12.6% across the board, we have much higher smoking rates in routine and manual workers, people with mental health conditions, and particularly people with severe mental illness can have really quite high smoking rates. We know that people with other substance and addiction challenges also have high smoking rates. So there's a high level of need in terms of support to quit among those groups. And we also know there's a high level of need in terms of parents-to-be. Smoking at the time of delivery is still around 10% in Thurrock, and with the long-term effects that can have, that's a key group for us to focus on as well. So in terms of overall reduction and that inequality reduction, those are the groups that we're particularly targeting. And we've identified those through a needs assessment that was done and brought to this committee in 2021. We know that although there's high need in these groups, our smoking cessation model does work for these cohorts largely. So we're aiming to embed the offer of smoking cessation within core services and within core situations where we can interact with people in these key groups. So, for example, embedding a smoking cessation offer in core mental health services. So it's not a separate offer, it's part of that core holistic care. Similarly, with people employed in routine and manual roles, we've now got an employment health, a workplace health offer. We're outreaching with employers and working with health champions in some of our big employers, and that work is already underway. So in terms of the delivery plan to develop this strategy, and I'm now on, I think, slide 5, we have 4 work streams. The strategy that's in your papers has a high-level delivery plan. There will be more detail in the detailed delivery plan, but I haven't shared all that with you today. We're still working on some of that detail. But essentially, there'll be 4 work streams. One is around prevention, so reducing people smoking in the first place. So there's clearly there a high focus on young people, working with schools, other organisations that work with young people, but also working with organisations such as trading standards to reduce the supply of illegal tobacco, for example. There's more work we can do on smoke-free environments. That's obviously, those sort of environments have increased immensely over the past few years, but I think there is further we can go in Thurrock, and we can learn from other local authorities such as Liverpool, who've gone further arguably than we have. So there's more we can do there. The third priority is helping smokers to quit, and that's particularly where that focus on those 4 priority groups comes in. We know that many people who smoke want to quit, but it's not easy, and the evidence base is that it's much easier to quit with support. So we've got a very strong evidence-based support offer. And then the final priority is around communication, evaluation and adaptation, and essentially that's learning as we go. Given that we now have much lower smoking rates than we have previously, and certain groups, such as people with severe mental illness, can struggle with quitting. We need to be responsive to the situation as it evolves. We need to be nuanced in our messaging to different groups, and we need to be listening and learning. Similar to the discussion that's just happened around safeguarding, we need to be in communication with those seeking our support, so we're offering the best solution for them. So that's very much about making sure that our strategy remains relevant during its lifetime. And then I'll just jump to the final slide. So in terms of next steps, we've presented this to the Health and Wellbeing Board this morning, and we're also sharing this with you now for comment and then agreement to publish. As I said, we will have a detailed delivery plan, and that will be monitored by the Population Health and Inequalities Working Group, which reports into the Better Care Together Thurrock Strategy Executive Group, which reports into the Integrated Care Alliance. So that will be our governance route and our oversight group. And I will stop there. Thank you.
Thank you, Jo. Any questions? Tony, Councillor.
I'm very interested in the prevention side of it. What can you do to prevent young people from starting smoking?
So that is a very good question. We have much lower rates of young people starting smoking than has been historically the case, but what we are seeing is larger numbers of young people taking up vaping. So there's kind of an interplay between these two issues. So this strategy here is very much focused on tobacco and tobacco smoking, but we do recognise, and one of the key delivery arms on that prevention bit is around working with young people and reducing both vaping and vaping becoming an addiction to nicotine and then smoking. So there's work going on regionally around this, and there's a position statement being developed between all the directors of public health in the region that we can then build our local approach on. But we already work very closely with young people's groups through the Brighter Future strategy. So this is a key part of strategic priority 2 for Brighter Futures. We're working with schools, with young people's groups, but also crucially, as I mentioned, trading standards. So reducing that access to vapes for under 18, so that illegal supply is a really key element of that as well. So it's a lot about messaging and understanding, I think, young people's attitudes, because it's quite different, I think, from the attitudes that my generation have to smoking.
I mean, traditionally, it was about peer group pressure. So is that still the case, and how would you deal with that kind of pressure?
So interestingly, at the Health and Wellbeing Board this morning, Michelle Lucas from Children's Services was saying that the feedback that they've been getting through some of the engagement they've been doing is that young people see smoking as really not socially acceptable now, whereas vaping is. It's a very different attitude that they've got. So that's what I mean. I think there's something we need to do about understanding those attitudes and making sure our messaging and our actions are the right ones. But I suspect that vaping still has that peer pressure element.
Haven't got anything else? Councillor Polling?
I'm just wondering, I suppose with the conversation it's just gotten, perhaps not the best of ideas, but vape shops, if people are going to a vape shop, people of my age group are probably looking to quit smoking. So the quit smoking services, again, coming back to voluntary sector and people that are running hubs, so in areas such as Purfleet-on-Thames and my area, Bellas, probably areas that we would want to target some of the more traditional hardcore smokers. The community hubs that chat over a coffee rather than that hard sell, quit smoking. Then you get the resistance of I've smoked all my life, and I just wondered where we are with approaching again. We've got a very strong, third sector in Thurrock, and and I think sometimes we reinvent the wheel. We've got those contacts to speak to them. I can remember years ago, South Hockenden Forum then offering smoking cessation classes, and it's one of those things that if they're within their local communities, if it's easy for people to get to and use, then rather than having to make an appointment for, I think when I did mine, it was in the Thameside Theatre, and it was only on certain days, and I could only do it. The more barriers you put in front of it, the less likely people are going to take up on it. That's my thoughts.
Thank you. There's a number of things there, all very well-made points. I think there's three things I'd just pick up on. Firstly, around vaping. The messaging around vaping is a little bit complicated because we've got two messages. As you say, if you're an adult smoker, vaping is a really useful tool to quit. And so part of our current smoking cessation offer, we have a number of ways, things that we can offer people like NRT, nicotine replacement therapy, or vaping, and they will have the same support from our service depending on what approach they take. So we do build that in. The second point around the voluntary sector, you must have been listening to us on the stairs earlier. Mark and I have literally had this same conversation today after the Health and Wellbeing Board. So the public health team are funding the CVS to host some community health champions for us. And one of the things we were talking about after the Health and Wellbeing Board today was exactly that, how the community health champions in their role out and about can be ambassadors for us, can talk to people about smoking cessation, link them in. So we're definitely on that. Fantastic. And then the third thing is about that removing barriers. And interestingly, unlike a lot of services during the COVID pandemic, where moving to a virtual model was quite difficult for service delivery, actually we had increased uptake of a virtual offer of support for smoking cessation, and now a lot of our smoking cessation is virtual. People don't have to come to a building, they can do it online. So actually our model has evolved massively and removed some of those barriers, but that's part of us in the strategy, keeping relevant so that we can keep responding to changes such as this as they happen.
Suspect.
It's a very simple question, really, and as somebody who can't wait for the meeting to end and go down to my local club and have a pint, just a simple question. Do we have a Thurrock alcohol control strategy in the pipeline or underway? Because I think this is an excellent piece of work and it's really going to pay dividends and everything. But equally, there are a huge amount of problems caused by alcohol. And again, in my working life, I came across a young man of 16 who's got some mental health issues, who solves his problems by going out and drinking lots of vodka. And I'm sure there are a lot of adults who are similar. So it would be, if there isn't one already, if you could get one on the stocks for when you've sorted this one out, it would be fantastic.
So we don't have an alcohol strategy per se, but actually we do have, I guess, a strategic approach that we're working to. So we've recently completed a drug and alcohol needs assessment. That is, if it's not already on the website, it will be very soon, so I can make sure I can send you a copy of that. It's a very comprehensive piece of work, and it identifies that there's a high level of need across all substance misuse, and it's a higher level of need than potentially we have the resources to address. So it's about being smarter and doing a harm reduction approach. So we do support people who have the highest level of need with any substance, who are willing and wanting to engage with services. But we're currently, literally, I think next week or the week after, about to go out to re-tender our drug and alcohol misuse support service, and so we've got a new specification for that service that we'll be asking people to bid against, and that harm reduction approach is very much part of that. So we've got a lot of work in the pipeline on that.
Ian Wake.
I think just to add to that, you've kind of alluded to it in your question, there's a huge overlap between addiction services and mental health problems, housing and care. And so the raison d'etre of our integrated care strategy, and in terms of the HOSC member briefing, I think we'll be touching on some of this. Is actually to try and bring that support and those professionals together at the locality level in integrated teams, such that when we encounter someone like the young person you speak about, we can design a single solution that picks up all of that. Traditionally, those things have been done in silos, and that's not really helpful. And I know Joe's worked really closely with the Integrated Care Alliance, and as part of the specification, it will require the new provider to co-design those services. Yeah. And there's some really brilliant work already happening in terms of some supported living, adult social care provision with drug and alcohol outreach workers that you've commissioned. And we're very grateful for that.
Yeah. Okay, thank you. I have a question. What are Liverpool doing which we're not?
The allusion to Liverpool, what they have done. So Liverpool, I think they were the city of culture at some point, weren't they? And so they've got a big focus on their cultural offering, and I suppose their nightlife offering in a way that is different to Thurrock. But what they've done that's quite clever is, in developing their cultural strategies, they've built in these things like requirements for smoke-free environments. They've built that thinking into sort of their licensing and planning decisions. So we do work a lot with our planning team, and we're doing an awful lot of work with the team working on the local plan. So I think there are things we can think about in terms of not just smoking, in terms of the wider determinants of health quite broadly, in terms of that place-shaping agenda. And I know that the working group we're going to come on to in a minute, for example, that what those wider determinants and what we can build in to address obesity. It's that kind of approach where some other local authorities, particularly those big urban councils, have gone a lot further than us. So there's quite a lot of work learning out there on that sort of thing.
Okay, thank you very much. Okay, if it's okay with members, do members agree with the following recommendations? That Health, Wellbeing, Overview and Scrutiny Committee note the contents and agree the publication of Tobacco Control Strategy 2023 to 28 and placed on the council website. Is that agreed?
Agreed.
It's agreed. Thank you very much indeed. Thank you. And a very good report. Thank you very much. Right, that brings me on to item 10, which is the agreed working group's terms of reference, which I hope all councillors have had an opportunity to look at. We agreed at the last meeting that we would be looking at two areas, which was mental health services, and I think kind of staying healthy, but that's really needed to be a better focus. So I think we agreed to look at obesity as being the main focus. So I don't really want to go through the whole thing. I take it, have you all read them? And in terms of the terms of reference, do you have any comments on the terms of reference, say, on mental health? No? Or obesity?
No.
No?
Okay.
Okay, so we can agree that we're happy with the terms of reference. Is that agreed?
Agreed.
Okay. The makeups of the groups are still being developed, but just to give people a flavour where we are, in terms of the obesity group, Councillor Polly has agreed to chair that group. And other members of the group, Tony Fish, and there's been interest by Jackie Maney. I think Health Watch are involved as well. I'm still looking for one more councillor, which I've emailed George Cockshaw about, and I'll also be speaking to more of the independent councillors, and I hope to have those groups completed very, very soon, with a view of actually starting to have some meetings in September. Okay. Right, in terms of the mental health group, that's myself, James Howden's expressed an interest. Sarah Maldoni has expressed an interest. And I think maybe, I need to confirm this, Councillor Liz Rigby has expressed an interest. Okay, I still again need an independent offer to the independents, and if the independents don't take up that offer, then I will look elsewhere. Okay? Right. I guess I need to work with officers to decide the meeting dates of the meetings. As I said, the groups will meet monthly for at least 4 months, with a review of the reports being ready by March next year. Okay. I'd like to discuss with Councillor Cockshaw at some point that I know the report will feed back to HOSC, but then what we kind of do with the report afterwards. Okay. Right. So, Councillor Spate.
I was just looking at the one co-op, and I know you don't want these organisations to become too unwieldy. Is one co-opted in terms of mental health? There are plenty on the other one. Is one co-opted going to be enough? Because there must be levels of expertise and people with knowledge that you could bring in. I just thought one might undercut it, but better people than I would possibly know that.
I think it's a fair point. But I need to make sure the group is big enough that it works. But I'm happy to look at other groups if they are interested in taking part. Jo?
Yeah, can I just come in there? So this isn't the only group that we're setting up at the moment around weight management and obesity. So in terms of weight management services, those commissioned and provided services, we've also got a group, an officer and NHS staff group. So I think merging the two might make it too unwieldy, but what we could do is have a sort of dotted line between the two or something. Obviously, I'll be in attendance at both, as will Kim, I think. So it's just a matter of making it work, I think.
Yeah, I mean, what I was thinking particularly was I wasn't. I mean, the obesity one's got a number of people, but I was thinking again what we were talking about earlier on with mental health, that we've got various sections, if you like. So I was thinking somebody who would primarily maybe look at younger people and their mental health, and then possibly someone who was looking at the older issues of mental health. So we have that balance of experience on the panel. That was what I was thinking.
I think it's something I'm really keen to also make sure there's. I was always keen that we don't reinvent the wheel across numbers of different groups. I really want, and this is why we've got members of children's services involved in these two groups, because mental health and obesity is an issue for both. Now, I know that that younger people services are also looking at obesity, and I really hope we can come together and do something jointly rather than keep reinventing the wheel. We've got different committees or groups doing the same work. It's just a waste of time and money. So I've tried to work or communicated with Liz Rigby, the chair of Children's Services. I've emailed George Cockshaw as the portfolio holder. So I'm hoping to bring children's and adult services together rather than do something completely, and particularly at that point where people move from children's services into adult services can be quite difficult, and try and get that as streamlined as possible. Okay. Councillor Polly.
Sorry, could I just suggest that we might have a conversation with Councillor Paul Arnold as well as Chair of Corporate Parenting, because I think sometimes when our younger looked after people make that transition from care to going out in the big wide world, they possibly are very vulnerable. And I would say in my professional capacity, one of the things that we are seeing a real heightened increase in is organically induced psychosis, which is coming from various substance abuses, and I think that is something that that needs to be addressed, as Councillor Spate alluded to earlier. That he mentioned alcohol, but I would say that my generation, a packet of smokes was quite normal, whereas I think now our younger people wouldn't go to tobacco products, but they may go well to more organic-based products that have come with them different health concerns. I welcome it. I think it's very ambitious. I just would like to know that we have got the support. Knowing that our resources, our democratic services, and all of our agents, all of our departments are very busy, and I just want. It's one thing to put on paper. I just don't know if we've got the delivery mechanism.
Ian?
So I really welcome this, and I think member input into this and political leadership of these two issues, which are both, as you have all alluded to, quite complicated, quite complex, I think would be really powerful. What I would say on the mental health one is, I think you would be, given that it's like almost saying, let's look at physical health. In terms of mental health, the breadth is so great that my advice to you, and you can look at what you want, but my advice to you would be to try and focus down, and that's what I think we try to do in terms of this terms of reference. So what we are suggesting is that you look at where we've got that complexity. So it's cases coming to the new MDT approach that we've set up, because I think there's some learning that in terms of how we can then reform and transform the system based on where things work or don't work. I think if you can keep it focused, my advice would be you'll probably achieve more in that time period.
Sorry, I mean, just to go into that debate, I mean, the reason why I'm sort of brought the comments that I made was that, and I may as well talk experience, I recently had the opportunity to spend a day in a youth court, which is not something that I'd done for probably 30 years. But I sat there all day, and the complexity of cases that came through during the course of the day with young people, mental health was on the agenda on virtually, not quite everyone, but certainly substantially more than half. And so you've got organisations like Youth Offending Services who are very integrated into that, and they bring knowledge. So, and I think what Mr. Waits just said in terms of picking a focus, then I certainly would like us as an authority to be looking at how we can really help young people. And the benefits of that are, if we help them, we will then cut down on criminality and antisocial behaviour and other issues, and we will help boost education. It really is a cause and effect. Well, that's the right phrase. If we concentrate on a particular area, and I would love to see that be in young people, and really bringing some practical help available, because it strikes me there isn't a lot. Having sat there and listened to all those stories and seen what I would used to call a probation service, wasn't very good, if I'm being absolutely frank with you. So if we as a local authority could have some input into helping those young people, I think it would be really, really positive. But I've said enough, so.
Thank you, Councillor Spayton. I think thank you for your comments, and I think duly noted. That's something we will look at. Thank you. Right, so are there any other questions about the working groups?
No.
No.
Good work, too.
Okay. I'd like to thank the officers and everyone involved in putting this together, so I know Health Watch has been involved too, for helping put the terms of reference together. I'm very, very grateful. Because I want to change the world, and that keeps me focused. Okay. Well, I'll just move on to the last item on tonight's agenda, which is the work plan for HOSC over the next year. I guess for me, do members have any questions or comments they wish to make on the work plan? Councillor Fish?
Just on the updates from Mid and South Essex Trust, I asked a question about haematology this evening, and I was told that she can't give specific comments on individual services. So, is her brief, or the person's brief is coming along, just to report on the ongoing CQC process? Or is there meant to be more to it than that?
I think from my point of view, there's more to it than that. I think there's a lot of challenges for health in this area, and I value someone coming to report back on how things are going within health. But I do think we may need to consider is being a bit focused on our questions prior to the meeting, and maybe emailing her so they've actually come ready and prepared for something would be kind of helpful.
That's exactly my point. Yeah.
Councillor Polly?
Thank you, Chair. On the 2nd of November, I noticed that we've got the update for Mid and South Essex Trust with Fiona, the MD or CEO that was here today. And we've also got Diane Sarker giving a report on the CQC from Basildon. Are we having... I don't know if that's... Are we having two presentations on the same thing?
I think Fiona is here to give us updates on what's going on within the trust. I think she's very honest and candid about that today. We've asked her some questions which I think in the main she's going to go away and look at. But I think we, at our last meeting, made a real point around the quality of care concerns there are around the trust, and that comes out clearly in the CQC reports. What I as chair, are really keen to see is the action plans for improvement, so the people of Thurrock get the healthcare they really deserve, which is, in my view, they're not getting now. Okay, so are there any other questions about the work plan? Councillor Polly?
The e-put update isn't until January next year. I think we might need some dialogue with e-put before then.
That's something I can go away and look at. Okay. So, if there are no other questions, can we agree that this is the work plan for the next year? Is that agreed?
Agreed. Obviously, it hasn't got a special meeting.
Okay. Okay. That being the case then, unless there's anything else, I will close the meeting
2058.
at 20:58.